Good morning, everyone. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. Just a reminder and announcement, next week we will be hearing the talk Debriefing, a Tool for Reducing Burnout, given by Dr. Adriana Morse, the current Chief Resident at our own Providence St. Vincent Medical Center. And now for a few logistics before introductions. Grand Rounds, as many of you know, is a joint effort between Providence St. Vincent and Providence Portland Medical Centers. We are often here live in person in Southern Auditorium at St. Vincent's on Tuesday mornings at 8 a.m. And we are occasionally live in person at Providence Portland at noon on Tuesdays. You can always join us virtually on the Teams Live platform. And you can earn CME credit by being live in the room, by watching live virtual, or by watching a recording of the event. If you look at each week's Grand Rounds invite, it will tell you where and when we are meeting and also has the link to the recording. I'll be monitoring the Q&A throughout today's session. So for those of you online, please go ahead and post any comments or any questions. And I will mostly hold those until the end as time permits. And now, today's speaker, we are joined by Dr. Becca Kennedy, a practicing family medicine physician in Portland, Oregon since 2002. She earned her medical degree from University of Michigan and completed residency at OHSU. After several years in general practice, Dr. Kennedy began applying evidence-based neuroplasticity techniques to chronic symptoms and led the long COVID specialty group for the Kaiser Permanente Northwest region. Inspired by the transformative results in 2023, Dr. Kennedy started her own clinic called Resilience Healthcare, which focuses solely on this neuroplasticity model to treat chronic symptoms. She is a board member of the nonprofit, the Association for the Treatment of Neuroplastic Symptoms, as well as a member of the Oslo Chronic Fatigue Consortium. Dr. Kennedy, thanks so much for joining us with your expertise today.
Thanks so much. Hi, everyone. Thanks so much for having me. I love being in a room with primary care clinicians. In case anyone hasn't told you lately, you're the bomb. You're the backbone of medical care. And I thank you from the bottom of my heart of showing up every day to work because it's a tough job. And hopefully after this, there'll be a few pieces of information that makes your job a little bit easier. So I'm going to be talking about, as Laura mentioned, looking at long COVID and other chronic fatigue syndromes, although this also applies to many, many other symptoms, through the lens of the brain and neuroplasticity. So the objectives are describing the new pain science and the role of the brain in generating symptoms, understanding how that fits in with long COVID in this paradigm, including with the medical literature, understanding how health disparities fit in, and then learning specific communication and resources for patients to help resolve their symptoms completely by focusing on the brain. My disclosures include my own business. I consult and provide content for the Curable Health app, as well as I teach and I consult for the Freedom from Chronic Pain course. So as Laura mentioned, I've been a family medicine physician for over 20 years. I was at Kaiser Permanente for 15 years. I'm also a board member of our nonprofit, and I'm a member with a group in Europe that also is spreading the information of the new science and really helping people to recover. So when you go into your office every day, many studies show that your patients look something like this. And the blue are organic disease, where you know what's going on, the tests are positive, it's clear that something is happening in their body. The purple are mental health issues, and then the green is medically unexplained symptoms. And study after study shows that a large proportion of primary care patients have medically unexplained symptoms. And if you look at this, it's over half your day is spent either with mental health issues or medically unexplained symptoms. And that's hard. It's really hard. This is what burned me out, actually, and made me leave primary care. And 10 years into my career, I was so curious about this triad that I'm sure many of you are well aware of just seeing the same sort of diagnoses, most of which do not have abnormal tests. In that same person, more often were mental health diagnoses as well. And then also those same people more often had a history of trauma. And seeing this pattern over and over and over, but yet sending someone to mental health usually didn't help with all these physical symptoms. And, as primary care clinicians, we send people to every single person we can possibly imagine, and then they come back to us and tell us everything that doesn't work. So we're at this unique vantage point to really understand the whole picture. And so 10 years into my career, I was burned out and I couldn't look at people in the whites of their eyes anymore and tell them I couldn't help them. And so I actually left primary care and I moved around from urgent care and emergency department. But it became this curiosity for me. It was like an itch I couldn't scratch. It's like, what are we missing? What are these missing pieces? And so I searched and searched and searched, and I found lots of different information at Harvard and Peter Levine and Bessel van der Kolk and, all these different people, but there was no answers of how people actually got better. And so one day a few years ago, I was talking to my best friend from medical school who stayed at Michigan in family medicine. And she said to me, "Oh, I send my patients with chronic pain to Howard Schubner and he fixes them." They come back to me and they say, "Oh yeah, Howard fixed me. I don't have pain anymore." And I was like, "Wait, what?" And I would have blown it off and thought, well, that's not possible, except it was my best friend from medical school and it was her own patients. So I looked up Howard Schubner, and it turns out he's been doing this for a couple of decades, very down to earth physician, does randomized controlled trials. And I found everything that he taught, and there's a whole community of clinicians and scientists around the world who are also doing this. And so again, this is the new science, and really it's about the brain. And it's not just about the brain, and I show this to patients, it's about the unconscious brain. And I think it's a really important piece of information to really know that, the light blue is our thinking brain, and the whole rest of the other brain, 90 to 95%, is our unconscious brain that determines if we're in danger, and that's the part of the brain that tells our body what to do. And so really understanding that this is about the brain. So this model that I'm going to talk about, this is a paradigm shift in thinking. And like any paradigm shift, there's a lot that's counterintuitive, and it takes decades to be integrated into the mainstream. And paradigm shift, that you can actually resolve chronic pain, that you don't have to manage it, you're not going to live with it for the rest of your life. And again, that is a huge idea that's hard to wrap your brain around. Our country has spent nearly $2 billion researching just long COVID alone, and really they're no closer to solutions. And they're looking in the body for the answers. So what I'm going to talk about is when we look in the brain for the answers, not only do all the pieces start coming into place, but actually there's concrete tools that we can work with patients to teach them how to change the brain signals, rewire the brain, and turn off the symptoms that are not helpful. Anytime that there's a whiff of the brain getting involved with describing a lot of these chronic symptoms, a lot of people can take offense, they don't believe it, and it can be a difficult conversation. Understandably, a lot of people have been dismissed by family, friends, doctors, and so it can be a delicate balance, but understanding the science and really fully being able to explain the science makes all the difference in the world, and that's what I'm going to talk about today. So I want to give you a little sample. This is a patient of mine that was at Kaiser, and I had just learned about this. I didn't know it very well when I met her. And so I'm going to show you how she talks about her symptoms.
Other symptoms I ended up with that appeared over time.
Can you hear that?
Brain fog, memory loss, difficulty walking, difficulty breathing, lack of stamina, flare-ups of arthritis and psoriasis, an itchy rash that covered my arms and legs, spiking blood pressure, hearing irregularities, heart irregularities, pain in my extremities, insomnia, persistent headaches, confusion driving, getting lost on my way home, vision changes, sensitivity to bright light, and greatly worsened dark night vision. This continued, and I got tested for everything in my body, and they all came up negative. For 3.5 years, though I rarely had good days, there were good moments. Sometimes I could not find my way home from the grocery store, or add 3 numbers, or cook a meal, or make it up a flight of stairs, or lift a coffee cup. There was not a moment that I wasn't tired, and even sitting still, my legs would hurt and start to tingle. Holding up my phone, which felt extremely heavy, made my hands go numb.
So she's had 3.5 years of all of these symptoms, seen everyone she possibly can see. She comes into your office, says this to you. What are you going to do? And if you suggest that this is her brain, or the problem isn't in her body, that's not necessarily going to go over well, as I'm sure many people have discussed with their patients. So after I talked to her, this is how she summarizes our conversation and how I worked with her.
The first thing she did was ask me what I needed. And as I explained the entire situation, and how healthy I'm supposed to be, and that I'm never worse, I'm just going on unable to do anything, she listened very carefully. This kind of amazed me. When she responded, what I learned from her in 20 minutes made sense right away. She backed it up with pages of references, some of them articles peer-reviewed in medical journals, and names of other people looking into the phenomena of mind-body connections. She did not suggest that what I was dealing with was a mystery. She told me she had an idea exactly what was likely going on. I will not try to paraphrase what she conveyed to me, except that I could tell intuitively that she was correct. It made perfect sense. My impression when I listened was that getting very sick with COVID and trying to recover was traumatic in the acute stage, and my entire body had gone on into ongoing emergency response. My different systems could not find my previous healthy rhythms and behaviors. For the past 3 years and counting, my brain kept responding with pain messages and bodily responses in different places, different days, that came and went, resulting in sensations that would warrant medical attention. Because I was scared of getting worse, I kept responding to the feelings I was having by my own alarm at seeing myself unable to function. Dr. Kennedy gave me a set of exercises, none of which required physical exertion, focus, or even standing up. They involved writing, meditation, relaxation, and an attitude I needed to adopt to retrain my brain. It was simply accepting COVID as a time in my life when I was hit hard physically, mentally, and in every other aspect of my life. I needed to retrain my brain to calm down and stop pulling the alarm. When I felt symptoms, I could notice them, and then I should accept them with a grain of salt and calmly carry on so my brain could learn new patterns, or really the old ones it had set aside when COVID changed the rules. That, in turn, would let my autoimmune system calm down and settle into a more normal way of monitoring problems in my body. That made sense to me, and when I tried it, I began to feel a little better right away. And in 2 weeks, I felt I was the person I had been before. I could begin to exercise, worked with a treadmill and resistance bands twice a week. And by the 10th week, I could walk 2 miles and carry on a conversation.
So that's Deborah, and this is her now climbing trees, playing with her grandkids, remodeling her house. So this is brain generated through the nervous system, and when we can understand the science behind it and explain that to the patients in a way that they can understand, then it makes sense. I was very scared to say this initially when I first learned about it and how patients would take it. And I was actually really amazed at how many patients were open to it. And many patients actually said to me, wow, this is the first thing a doctor has told me that actually makes sense. A lot of people do intuitively know that this is their brain and their nervous system. They just don't know how to get better or exactly why it's happening. So let's look at how long COVID and all of the information that we know about it fits in with this model of brain and nervous system issues. And then I'll talk about more of the pieces of the science that really bring it all together. So as clinicians, we see patients, we see what's happening in front of us, and we need to then connect that to the science and what we know about how the body functions. We don't have the luxury of just dismissing some of the pieces of information because they don't fit in the box. We have to take all of the information and see how it makes sense. So this is per the CDC, the definition of long COVID, and there's all these different elements to it. So if you look at some of the elements, it has a wide range of symptoms, over 200 symptoms, but yet no abnormal tests. The symptoms can come and go. They can go to different parts of the body. Sometimes the symptoms happen directly after the COVID infection, and sometimes the COVID infection, in fact, most of the time, is actually just a mild or a moderate infection. Most of the people with long COVID haven't actually had a very, very severe infection. Sometimes their symptoms can be delayed. Their acute infections gets better. They feel fine for a few months, and then their symptoms of long COVID start. So how does that make sense if it's happening due to some sort of damage in the body that the virus is causing? Another piece of information is that the symptoms worsen after physical effort, but also worsen sometimes after mental effort. Again, how does that make sense if there's some sort of spike proteins or some sort of damage in the body as the cause of the problem? The predominant group of people who have long COVID are middle-aged adults. People who are over the age of 65 are actually less likely to have long COVID. So again, if we look at a frail, elderly, sick person and their body, if you think about that the virus did some sort of damage to their body, it would make more sense that they're the demographic that have long COVID rather than robust, healthy people that are middle-aged. So looking at health inequities, unfortunately, like everything in medicine, this affects long COVID as well. Women are 30 to 45% higher risk of developing long COVID than men. People in Latinx communities, bisexual identifying, transgender, people with disabilities have significantly higher rates of long COVID than people that are not in these marginalized groups. Again, looking at the chronic stress state that people with the health inequities are in and connecting that to the rates of long COVID. So in clinical experience, I'm sure many of you have experienced this. So again, I was the lead of the long COVID clinic at Kaiser. There's 500,000 members, and we were a small team that did chart reviews of all the people with long COVID. So I assessed hundreds of people with long COVID and worked with many of them one-on-one. So some of the patients had had a COVID infection after they developed long COVID. Makes sense. But again, many of those infections are just mild or moderate, not severe infections. But some people actually hadn't had a COVID infection at all. And this was back in 2021 before everyone had COVID at some point. So some people developed long COVID just after having the vaccine. But I have some patients who developed long COVID symptoms within 5 minutes of getting the vaccine. Like, no joke. They said, "Oh, I saw the nurse's face. She looked at me and said, 'Oh no,' when they, had all of these symptoms that came in, and then those same symptoms and more developed that were lasting for years, and they attribute it to a vaccine injury. That's just not how our body works. The vaccine doesn't cause damage in our body within 5 minutes that then lasts for years. But then other patients, they get the vaccine, they do fine for months, and then they develop symptoms of long COVID, and then they attribute those symptoms to a vaccine injury, even though they were feeling fine for several months. So again, how does it happen that there's structural damage that's happening from the vaccine, but yet it didn't start for months? And again, looking at all of these patterns. But even more interestingly, I don't know if any of you have had patients say this to you, but in back, 2021, patients said to me, without me eliciting this, I have long COVID, but I neither had COVID nor the vaccine. And these are the same symptoms I had before the pandemic. They're just worse, and they're the symptoms of long COVID. So early on, clinically, experienced that you could have long COVID without actually even having COVID itself. So how does it all work? The patients aren't making the symptoms up, right? The symptoms are real. So what are the missing pieces? So let's first just look at the science of long COVID and the studies that have been done. And there's all of these different thoughts and hypotheses, but many of these studies are extremely small. Some of them use questionable scientific methods. They haven't been reproduced. And actually, many of these changes are biochemical downstream changes that happen when we're stuck in sympathetic drive in the chronic stress state. So a lot of patients read these studies and they assume that it just means that this is real, this is reproduced, and this is corroborated, but it hasn't. They're just theories. So let's look at a few of the studies. A study on the theory about viral particles being stuck in the body, and that's the reason for the symptoms. Swank et al. In 23 did a small study, and there was just 31 patients with long COVID in the study. 65% of them were found to have persistent spike proteins. That wasn't all of them, it was 65%. The 35% didn't have persistent spike proteins. And actually in the paper, it's very difficult to tell how many of the controls had persistent spike proteins. They didn't actually report on that. They did do this study again, a larger study in 24, 578 patients with long COVID, 43% of them had persistent spike proteins. Again, not even half of them had persistent spike proteins. So there's all these other people with long COVID that's not from spike proteins, but then the healthy controls who had had COVID but did not have long COVID, 21% of them had persistent spike proteins. So again, there's this idea floating around out there that it's because of these persistent spike proteins, but the data really doesn't support that. So another theory about the microblood clots, there was the studies out of South Africa. In 2021, it was just 11 patients that were found to have these so-called microblood clots. They did another study in 2022. There was 80 patients. However, the methods were not elucidated in their paper. It was very difficult to figure out exactly what they did. Fox et al. In 24 did a review of 5 studies and found that a lot of them were poor studies, again, very small, and that it was actually amyloid fibrinogen particles that they were identifying, which are not actually blood clots. They're the precursors to blood clots, and that these precursors can actually be found in people that are in chronic inflammatory states, which, being in the chronic stress state, develops a chronic inflammatory state in the body, and that these fibrinogen particles were also present in healthy controls, for instance, people with diabetes that did not have long COVID. So again, the theory and the idea has not been corroborated. There's people in Europe that are going to these centers and they're getting plasmapheresis to clean out the micro blood clots in their blood. I mean, the tragedy of all of these things is people are choosing to do actually dangerous things that could cause more problems. In 23, Nature published a study that they found biomarkers in people who had long COVID. And what the biomarkers were immune cell changes, antibodies to EBV and HSV, and decreased cortisol. And again, these are non-specific biochemical changes that can often happen or can also happen when someone is in a chronic stress state or chronically stuck in sympathetic drive. These are biochemical changes that can happen in the body. So again, not specific to COVID itself. So if we look at the studies that have been done where there's the hypothesis that long COVID is happening because of some sort of damage in the body caused by the COVID virus, the studies are small, they haven't been reproduced, and some of them have questionable scientific methods. Also, a biochemical stress response can also be causing some of those findings. Jaffe et al.'s paper in 23 is a great review that looks at all of these studies and then talks about the theory of long COVID through the Bayesian perceptual processing, which is what I'll talk about more. So another piece of the information I want to talk about specifically is the symptom of brain fog. It's very, very common, and it's very scary, understandably for patients. But we've known for a very long time through doing studies with functional MRIs that the prefrontal cortex is the brain region that's most susceptible to stress exposure. How I explain it to my patients is that when the danger part of our brain is dialed up like a dimmer switch because it's perceiving danger, our prefrontal cortex, our thinking part of our brain, is dialed down because we don't need to be doing math when we need to be running away from a saber-toothed tiger, which is why you can practice your speech 1,000 times. You get up like where I am right now, and then your mind goes blank because the activity of that part of the brain gets dialed down. So if we are chronically stuck in a stress state, the activity of that part of the brain is dialed down. I have many, 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 many patients who have had brain fog that has resolved with this approach. And very sadly, I also have many patients who were told by their clinicians that the reason for their symptoms was because of brain damage caused from the COVID virus. And it's just not true. And that puts in so much more fear for the patient that then actually makes the problem worse. It's understandable if all we understand is that some sort of damage in the body is the reason for symptoms, then yeah, it can make sense to put the pieces together like that. But again, there's no scientific evidence to show that. So now let's look at the large-scale studies that have been done about long COVID. So again, thinking about this through the lens of the brain, threat physiology, the nervous system, there's been quite a few studies that have shown that having a history of mental health issues predisposes someone for developing long COVID, as I'm sure is your clinical experience as well. So Taquet et al. Looked at over 200,000 patients and found that there was a significantly increased risk of developing long COVID with having history of PTSD, anxiety, depression, other mental health issues. Wang et al. Looked at 55,000 patients and found a twofold increase in developing long COVID if someone was under psychological distress. So again, these large-scale studies really reinforce the idea of the problem being in the brain and the nervous system rather than in the body. Looking at lab tests, the University of Colorado looked at over 10,000 patients with long COVID and looked at 25 different lab tests and found no meaningful differences between the patients with long COVID and those without. So again, not finding the answer with structural damage in the body. The University of Michigan looked at patients with a history of chronic overlapping pain conditions. And those are things like fibromyalgia, chronic fatigue, headaches, chronic back pain, and found that people who had a history of these sorts of illnesses, which is the same sort of brain nervous system generated problem, were at significantly increased risk of developing long COVID. And they looked at 3 million patient charts. And what's interesting is they found that the risk was increased 47% after having COVID, but it was actually increased 39% after not having COVID and just having the flu. And then they also found that many people had neither had COVID nor the flu, but they also were diagnosed with long COVID with having the history of the chronic overlapping pain conditions. So again, as we really expand and start putting together all the pieces, many people have the diagnosis of long COVID, but haven't actually had COVID itself, have a history of mental health issues, all of these pieces coming together. So when we look at a known condition, post-traumatic stress disorder, which has been described for thousands of years, actually, post-war. And we look at the symptoms, the vast array of symptoms that have been described for hundreds, thousands of years in post-traumatic stress disorder. These are really the same symptoms that are described in long COVID and other chronic conditions like this. And these symptoms are, again, really about the idea of threat physiology. This is how our brain and our nervous system works. When our brain is perceiving that we're under threat, this is the result of what's happening in our body because of these brain messages. So then looking at, if we think about it through PTSD, let's bring ourselves back to what was life like during the pandemic? What was happening? Actually, let me look at this first. So really think back to the pandemic. It was traumatic, and it was really traumatic in every sense of how it possibly could be for our human survival brain. We could die just from one little viral particle, and we could otherwise be healthy. We don't know where that's coming from. It could be from our grocery. Our safety net of our medical system is not there for us. We usually don't even think about it, but we can't even access the emergency department. We're separated from other humans. We can't even see their faces. And other humans is what provides a human brain safety more than anything else. And then add to this, there's no end in sight, financial ruin, all of these things, but then also the shame that was associated with getting a COVID infection. And you roll all of these things in, and then you take someone whose brain is hypervigilant, whose brain has been through a lot of trauma and stress throughout their life, and then you roll that in, and it really spills over the bathtub in our brain of trauma and stressors. And then these symptoms get put into place. They get created through threat physiology. And then if you don't understand that that's what's happening, then you get stuck in this fear symptom loop, and it just keeps going on and on and on. And that's more of what I'll explain. So again, the summary of all of these pieces of that I just went through really reinforces that the problem is the brain and the nervous system, not structural damage in the body. But what are the missing pieces of science to truly explain this? And this is what I think is really the key of how to understand it ourselves, how to teach it to patients, and then also how to get people better. So the new pieces are the new neuroscience of pain and the idea that all pain is generated by our brain, 100% of pain. It's a danger signal, not necessarily a signal of tissue damage that I'll talk about. The other science is, that piece of science is the idea of predictive processing, that our brains are prediction machines. And the vast amount of experiences is actually happening because our brain is predicting what's happening. And then the third piece is a conditioned learned response, which we all know about. And I'll talk about how it rolls in. So I used to think, what I was taught, that when we experience pain, and I'm starting with the example of pain first, just because I think it's most easy to understand, is that pain is generated by the nerves out in our body. If I break my hand, it's the nerves out in my body that makes the experience of pain. But that's not actually how pain is made. So if we have an injury, we break our leg, pain's not made yet. The nerves transfer the information that there's damage in our body to our brain, and then pain still isn't made yet. Our brain then interprets this signal coming in from the body to decide, does this mean danger or safe? And it uses all of the information that we've gone through throughout our life as well as lots of different other pieces of information to decide, is there something that needs my attention that's dangerous? When the brain decides this, and this is all happening in that 90% of our unconscious brain, it then creates the warning signal of pain, and it's generated in our brain by neural circuits. And now we experience pain that we're feeling in this very specific location out in our body, but it's generated by our brain. So pain is a warning signal, not a tissue damage signal. And it can happen because of tissue damage, but not necessarily. And so our brain doesn't always get this right. This is a prediction. So we can have an injury and no pain. So if that zebra sprains its ankle, or the soldier that got shot in the leg, pain actually would not be protective in this circumstance because they wouldn't be able to get them to safety. So the brain actually often doesn't make a warning signal of pain in that circumstance. And so you can have an injury with no pain. You can also have pain and no injury. This is what phantom limb pain is. This is what my tension headaches were that I got at 3 p.m. every day when I was working primary care and I had 2 little kids and my husband was working full time. So our brain can create pain with no injury as well, because all pain is made in our brain. Coming onto stage, having stage fright, someone might get a headache or a back pain or dizziness or tingling or, digestive issues shut down. We all understand that. We all understand how emotions can also create symptoms in our body, and we don't question that. But when they're chronic symptoms, I think that's what it's harder to wrap our brain around. So understanding again that all our experiences are pain as well as dizziness, nausea, zaps, all these different sensations, those are all being generated in our brain. And the second piece of information is the new neuroscience idea of predictive processing, that actually our experience that we have in the moment is largely happening because of our brain predicting what's happening, generating our experience through our neural circuits, and our sensory organs bring the information in from the world, and that largely serves to reinforce what our brain already predicted is happening. And this formed because it brings us safety. If we can predict a saber-toothed tiger jumping out of a bush before it happens, we're more likely to respond. There's also millions and billions of pieces of information coming in at us from the world, and that's too much for our brain to just de novo create every single experience. It has to categorize it and predict it. And mostly our brain gets this right. And when that happens, we don't even notice. It's seamless. But when it's discordant and our brain doesn't get the prediction right, that's when we notice. So if I bring this up and I think it's water and I take a swig, but it's really juice, even though I like juice, I do a spit take because my brain perceives that as danger because the sensory stimuli did not go together with what my brain predicted. And so our prediction machines are now in place and predicting what's happening, predicting in our body. I bend over. Oh, I have back pain every time I bend over. And maybe it started with a physical injury that healed, but now through prediction and that pain is created in the brain, now that neural circuit is stuck in place like a learned habit. So now maybe they've had back pain for 20 years, even though there's no injury anymore. So rolling into all of this, what we know about Pavlov's experiments with a conditioned learned response. The brain is always making meaning of all the pieces of information in the world, and all it cares about is, are we in danger or are we safe? And so different pieces of information like this computer screen, my brain can roll in and create meaning that I'm in danger. If I go to work and I look at a computer screen every day and I'm stressed out, then my brain can start to associate that light with danger, and then maybe a migraine starts. So all of these pieces of information are happening through our brain and our nervous system. So again, our brain perceives danger And when it perceives danger, it then needs to communicate with our conscious brain that something needs our attention. That can happen because of a physical injury, right? That's one of the reasons. It can also happen because of stress and emotions, stage fright, lots of different things, having a tension headache at the end of the day. The more our brain has been through trauma and danger, the higher the ACE score, it sensitizes our brain. Now our brain has learned all of that meaning, all of those conditioned responses around the world. So now through expectation and prediction, that person's hypervigilant brain is more likely to be interpreting signals that come in as if they're danger and creating that symptom or that interpretation of the world that there's danger, and then it creates the symptoms. And the more that we fear the symptoms, we focus on them, it serves to just increase that danger. And then we're stuck in this cycle. So maybe it started with a physical injury that now has healed, or maybe it started with stress and emotions and the pandemic that actually someone is through. But meanwhile, this learned neural circuit is in place, stuck in place, and stuck in a fear symptom loop. And many chronic conditions, this is what is happening. It's really about the brain and the nervous system, again, rather than some sort of structural damage in the body. So as clinicians, we need to make the right diagnosis, right? And lots of times the diagnosis is structural damage in the body. We are awesome at identifying and treating that. It's fantastic, but a lot of times it's not. I was flabbergasted at how few times the studies actually showed up positive when I first started practicing. And what happens is that in what we call it is neuroplastic symptoms, to really understand that this is real. This is about the brain and the nervous system. This is just how we function. But this is the warning signal that's stuck in place and the fire isn't there. And we can teach people how to turn off that warning signal. So the scope of this talk is not to talk about all the nitty-gritty about what that looks like. That's the part that I dove into because I wanted to pull the levers and push the buttons and really know, what is this? Like, how did Dr. Schubiner get people better? But what I'm going to leave you with is just a few things that you can start with now, which is how you talk to patients about this and how you connect them with resources. And the patients need to understand the science. This is about the brain and the nervous system. We're not saying that the symptoms aren't real. We're actually now explaining why they're having these very real, incredibly overwhelming and debilitating symptoms. And then they need to reduce the fear around the symptoms. And that's a lot of getting better. And then also understanding why their brain is perceiving threat, why they have a hypervigilant brain. So for many people, they do have a history of trauma and a high ACE score. And so it really requires more processing deeper down to teach their brain and uncover the things that are that they are have learned. I'm not going to go through this. This is just sort of an overview of a lot of the different tools that we use. At the bottom is breathing and meditation, and I very specifically put that at the bottom because these are the tools that people often think about, and those are the only ones that they know. And they do a lot of them, they get frustrated, and they're like, well, that's not really what's going on. I've tried all these things, but that's such a small part of what it takes in the concrete tools to get people better. All of the tools are things that they do themselves. None of it is medicine or external procedures or anything like that. It's really them retraining their brains, but they need to understand the actual tools that are effective. So I'm just going to briefly go over, there's been actually quite a bit of science that's been done around this in studies. This is a Harvard pilot study. It was 23 patients with long COVID, and they used this approach, this brain-centered approach, and they looked at 8 different symptoms, and this is how much the symptoms were decreased within just a few months. And again, no medicines, no external procedures. This approach is based on chronic pain, which is what it's been used for the last several decades. And this was a randomized placebo-controlled trial on patients that had had chronic back pain for an average of 10 years. And within several months, 2/3 of the patients were pain-free or nearly pain-free. And they compared this to an open-label placebo of a saline back injection. And this persisted at a year follow-up, and they're now looking at 5-year data and finding the same thing. Harvard also did a study on chronic back pain using the same approach and used an active comparator with mindfulness-based stress reduction and found that 2/3 of the patients after a few months were actually completely pain-free. And there was only a very small improvement with a mindfulness-based stress reduction. You can see the magenta line at the bottom, and then usual care is the green at the bottom. This is another study using or looking at vets at the VA and UCLA using the emotional awareness and expression therapy, which is one part of it, approach versus cognitive behavioral therapy, which is the predominant therapy that's used in pain clinics. And you can see that the orange line is 30% reduction in pain. That blue line is 50% reduction in pain. And the green line is 70% reduction in pain. And that's using this emotional awareness and expression therapy versus the CBT is trying to solve a non-cognitive problem cognitively. And we need different tools, which is why it's not very effective for this. So when I first learned this, I was astounded to find out that people around the world have been doing this for decades, clinicians, scientists, thousands of patients who have gotten better. So for our nonprofit, I organized having these videos made in order to represent this a little bit more. And this is one about skepticism.
So my first
and one just piece is many of the patients in this have long COVID, including Lucy right here.
reaction was that I didn't fully understand how this approach could apply to me.
What do you mean there's pain that my brain is generating?
That sounds ridiculous.
Like, what does that have to do with this MRI I have with the herniated disc?
I don't know about that.
I am in a wheelchair, and this should help me. These exercises should help me to walk again.
I couldn't exercise. I couldn't move. I couldn't focus. I couldn't even remember the names of close friends. I would have never believed that all my symptoms were caused by my brain.
And she had chronic fatigue syndrome for 13 years and saw 50 different clinicians, and it's completely.
I'm Dario Zagar. I'm a neurologist with Yale University, and I've seen hundreds of people with chronic pain and other issues improve with these treatments.
I'm Brandon Yarns at UCLA, and I've seen 2/3 of patients with improvements.
80%.
I have seen the majority of my patients.
Hundreds of
Probably at least 80%.
80%.
The majority of my patients.
The majority, hundreds of patients.
Thousands.
Dozens.
Over 7,000.
Treated over 4,500 patients with stroke.
Thousands of people.
Boulder Back Pain Study found that of the people we treated with chronic back pain, average duration of pain was 10 years. 3/4 of them were virtually pain-free in 1 month. In a study at Harvard, Mike Donino, our colleague, found that 2/3 of the people he treated, again with chronic low back pain, were virtually pain-free within a couple months.
Pain gets really learned in the nervous system. And just as we can learn symptoms, we can unlearn them.
The most important thing to know is that if you've had pain for more than 3 months, there's almost definitely a component of it that is your nervous system trying to protect you by amplifying or creating the pain. And there are these incredibly accessible approaches that are non-addictive and non-invasive that can bring down that pain. And so the fact that you're hearing about this now, whether you are fully confident that it's your whole problem or not, you should try it.
It just works.
Being where I am now compared to then is like, I mean, it's like a gift every day.
It feels like a second life.
It's pretty hard to put into words what it means to me to have gotten better, but I will say that
It was my fondest dream that I couldn't have even imagined that I would have. And when I did, I felt like better than I've ever felt in my entire life.
So
again, this is a paradigm shift. So looking at, this is a lot. There's a lot to talk with patients about, get them better, concrete tools. Many of the tools can be disarmingly simple, but they're not necessarily easy. But what the takeaways for you and what you can implement is the way to get someone on board is really with compassion. What all of you know how to do really well is be compassionate with people, really listen to them, really make sure that they feel heard, that their symptoms are heard, that you really understand it. And ask them about what's going on in their life, the stressors that they're undergoing now, and also stressors prior in their life, and connecting the dots, really reassuring them. People want to know that they don't have cancer or some rare thing and they're going to die. They want to know that you have seen this before, and reassuring them that you have seen this, because I'm sure you have many times, and that now there's new science to understand why, not only why this is happening, but tools in order for them to get better, and then connect them with resources. So the nonprofit, the Association for the Treatment for Neuroplastic Symptoms, is the central hub where you can connect with clinicians all around the country and the world, resources for patients. Dr. Howard Schubner is my mentor, and he has a free course on Coursera called The Reign of Pain. He has a great book, Unlearn Your Pain. It's very dense. It is written for patients, but all the answers are in there. There's apps, the Curable app, Free Me Health. They teach the science, teach the tools. Again, there's lots and lots of different resources. People can learn it from, books and online classes, all of these different places. Any of you are certainly welcome to contact me. I teach a virtual class. If any of you wanted to connect up with it, you can watch it on your own time, not just live. I have tons and tons of resources. This page of resources is a few of the ones that you might be interested in specifically. And then this is my patient, James, who had long COVID at Kaiser. And after 10 months of working together, he came after being on disability for a year and a half. It was like a primary care provider's dream. He came in and he asked me for a work release note to let him go back to work full-time and unrestricted. So with that, thank you so much for having me. Now there's just a few minutes left.
Many thanks, Dr. Kennedy. We'll take questions here in the room.
I was fascinated to learn, I was unaware of this, about the persistence of spike protein, as I thought I could think of three possibilities. It certainly doesn't degrade, or is there a persistent COVID viral load, or does mRNA persist longer than I was under the impression?
Well, I think the idea that persistent spike proteins are the reason for long COVID is not necessarily, bad theory, but again, it may be that some of the people do in fact have persistent spike proteins. Perhaps their immune system is not clearing the spike protein as well. But when you look at, is that what actually makes sense that's actually causing someone's symptoms? It really doesn't fully explain that. And part of it too, as I'm sure many of you have seen, is that often patients' symptoms come and go. Sometimes they're worse, in the morning, better in the evening, or they're gone for a week or a month and then they come back. So then, how does that make sense that it's due to spike proteins?
Thanks so much for your talk. I really appreciate this new perspective, and I'm wondering how well it has been received by patients who have chronic, if you want to call it central sensitization or whatever, and are on opioids. how has it been received? What do we do with the opioids as they're going through this, and what happens down the road?
Yeah. So when I first started doing this, I was working in the integrative clinic at Kaiser, and so saw hundreds of people, and I was surprised at how many people were open to it. And what I find is, just throwing out a nugget and saying, "Hey, there's new science," and again, doing it with just matter of fact, compassion, really understanding. And often when people would say to me, wait, what are you saying? And I just meet that and say, I know, right? I couldn't believe that this was the case. And really be open to them saying that, and just saying, hey, there's new science. Are you interested in hearing about it? There's been some people that have really had success. And again, just sort of seeing how open they are to it, and connecting resources, and just seeing how they respond. The way that I work with medicines with patients is I don't touch their medicines, and put the tools in first so that they start seeing some improvement from the tools. And then when they get better, then weaning down the medicine. Otherwise, it can just create too much fear in the brain.
I found this really interesting. Thanks so much. I was wondering what the time commitment looks like for people to do these tools. Like, how much time per day are people using? Is it things they need to be doing every day, multiple times a day, or can it be done a few times a week? And are there any barriers there to people engaging with the tools because of the time commitment?
Oh gosh, yeah, great question. I mean, it's just so different for everyone. And essentially, it's really about, starting with understanding that their body is not broken. This is about the signals stuck in place by the brain, which is, again, a radical shift. It is not easy. And the more that they can start leaning into activities and using things to calm their brain is what's important. And then some people need really a deeper psychotherapy dive to really get deeper down into the history of trauma. But it doesn't necessarily take a lot of time of things to do. It's more about sort of the approach and how you're connecting in the tools.
I'll ask a question that came up. Maybe building off of that, can you comment briefly on your approach to supporting disability and time away from work, perhaps ideally to create space for this type of program, sort of at the same time of promoting healing?
Yeah, right. So my particular approach was, I give people whatever time off they need, wholly and completely, and absolutely support that, because I think that people need that support just like they need if they had cancer. This is a medical condition. This is not something they can just turn off, and they need that space in order to work on things and rewire it sometimes, especially if they're currently undergoing a lot of stress. So I would give them that space in supporting them and being compassionate, while also holding space for, and there's also these tools, and I'm going to help you learn what the tools are and hopefully get you better at the end of this. And really, again, like I would do with any other medical condition.
Great. I want to honor we're getting close to 9. So if our answer runs over, please feel free. But I did want to capture just a couple quick questions online. One is, are there broader applications such as post-concussion syndrome, which can have similar complex symptoms that may come and go? I would assume that's a yes.
Yeah, it's really actually flabbergasting how many conditions this affects. Fibromyalgia, post-concussion, the vast majority of chronic back and neck pain, pelvic pain, really CRPS, really so many things.
Great. And then lastly, a very specific question. How does this compare to dynamic neural retraining that is discussed by Annie Hopper?
I find so what that is brain retraining, DNRS. It's similar. I can be very, very helpful for many, many people. I find that like the tools that I use or that I learned to use from Howard Schubiner or that other people use dive a lot deeper than just the brain retraining programs and going more into emotions, processing trauma, things like that, where the DNRS brain retraining programs don't do that so much.
And with that, we are at 9 o'clock, beginning of a paradigm shift.
Yeah, right. Awesome. Thanks so much.